Well, hello everyone. It's Rob Arntfield speaking to you from Western University in London, Ontario, Canada, where I'm an intensivist trauma physician and cross-appointed to the Division of Emergency Medicine as well. And in my practice, I use echocardiography at the point of care routinely. And something I've noticed over the past several years that I've been teaching this modality is that there's increasing interest in the point of care echocardiographers out there in understanding where and when and how to apply a quantitative approach to point of care echo. And I've struggled with this topic a little bit along in my own journey insofar as learning these skills and really trying to find the right place for them. And so this tutorial or webinar is designed to try to bridge that gap that I think currently exists in a lot of the education out there and to highlight for you some examples where this may be helpful. So this webinar entitled Resuscitative Echo, Visual Assessment and Doppler Measurements is going to be a wandering tour through both the visual approach and the quantitative approach to left ventricular function for the most part. And we, of course, have a disclaimer that this presentation represents a lot of my opinion and shouldn't replace good training. And, of course, this is true of anything with a procedural base. You need supervised training in order to become competent. So please, I hope this is thought-provoking, but please put it in the context of your own training environment. The objectives for today, as mentioned, are to appreciate that the visual assessment alone is 90 to 95% of the time all that you need. And that remains true no matter who you are, I believe, if you're practicing acute care medicine and you need to answer big, bad hemodynamic questions at the bedside. A visual approach is all that's needed. Put the calipers down. However, we will identify a few scenarios where quantitative approaches may be demonstrated to be useful. And we will also maybe demystify or debunk maybe one or two approaches to quantitative echo that I'm not sure have a lot of merit at the bedside, but that's entirely for you to decide at the end. So really these objectives more simply boil down to whether to use the eyeball or whether to use the calipers, and more on this as we go forward. I must open with and insist on, however, what I do teach routinely, and I believe most of my colleagues do as well, and that in general, basic echo, as it's known, or basic critical care echo, as I refer to and is referred to in my practice of intensive care medicine, is all that is required for resuscitative management of shock the majority of the time. Basic echo is comprised of things like gross left ventricular function assessment, gross RV size and function determination, addressing the IVC and its value in informing us about volume status, as well as things like cor pulmonale or tamponade, and addressing the pericardium head-on and looking for fluid in the pericardial space. Addressing these four broad systems and questions gets you 90 to 95% of the way there. And I'd like to review the eyeball approach in particular with the left ventricle and highlight its value and why we use this approach. Well, the literature featured at the bottom here is very clear. Across multiple specialties and in multiple decades, we've demonstrated that point of care practitioners using a very pragmatic training approach can routinely and accurately assess LV function and are very accurate when compared to a gold standard of diagnostic echocardiography. So when you look at this ventricle in the parasternal long axis, whether you know how you're doing it, which I'll talk about in a moment, or you're just doing it with a gestalt, your impression, after very little training, will accurately tell you that this ventricle is not one that is a complicating or culprit left ventricle capable of causing critical illness. And this is the eyeball method at its essence. By comparison, many of us have also been urged by more classically trained colleagues or those from different backgrounds that one must always use the Simpson's biplane method of discs when determining left ventricular function. And for those of you who may not be aware of this method that is routinely used by echo labs, This method requires two orthogonally obtained views, typically the apical 4 and the apical 2 chamber, and measures the LV cavity at both end systole and end diastole in each of these views. So 4 views, 4 measurements, detailed tracings of the LV cavity can be done at the point of care, and this will give you an exact number, which is very appealing, as we will discuss soon. However, this exact number is of little value in many cases clinically when trying to decipher whether the shock is cardiogenic or not, for instance, as this exact number, as we know in many cases, can be misleading. An ejection fraction of 80% can be just as concerning in some cases as an ejection fraction of 30%. And what really is the difference between an ejection fraction of 35% and an ejection fraction of 30% clinically for a patient in shock? And is it really worth that effort? And so with that all in mind, we've really moved away from the quantitative approach to determining left ventricular systolic function, and instead we celebrate and rejoice in the eyeball approach for its pragmatism, its speed, and its accuracy. So you should be assessing for myocardial thickening, endocardial excursion, making sure that endocardium moves towards a centric point in the LV cavity, and of course, when it's visible, does the mitral valve open freely, something called EPSS in the classic echo literature. Ultimately, the mitral valve leaflet on the anterior side should approximate the septum if the LV function is good. These 3 easy visual cues will allow you to interpret left ventricular function with a great deal of accuracy and sort through your patients as to who has LV failure and who does not most of the time, as we will discuss shortly. When considering the eyeball method, we've kind of ditched the continuous EF from 10% all the way up to 100% kind of approach to things, and instead have been lumpers, you could say, and have lumped classes of ejection fractions into categories that allow us to more appropriately triage how to manage our patients with maybe volume or inotropes, or perhaps leaving them well enough alone. And those 4 categories are hyperdynamic, normal, mild and moderately dysfunctional, and severely dysfunctional. So I'm going to review these eyeball approaches. For many of you, this may be old. However, it is a necessary prerequisite to the discussion that will be ensuing shortly. So we have hyperdynamic function, where the end systolic cavity size is nearly 0. We have nearly complete obliteration of the LV cavity, as is seen here in the parasternal long axis. By comparison, a normal heart looks comparatively a little bit sluggish, remembering a normal ejection fraction is between 50 to 70%. However, we see thickening, we see excursion, we see mitral valve movement. This is a normal left ventricle in the long axis. Stepping down a little, the less reassuring heart, the one that could really complicate your management for a patient potentially, is this mild to moderately dysfunctional heart, where it's probably not itself capable of being an isolated cause of death in a patient, but can really get in the way if it's related to previous coronary disease, or maybe it's a septic cardiomyopathy. These are really important to identify. And of course, then the severely dysfunctional heart, the ones we want to sniff out right away. We want to understand that if we're dealing with this heart, we may manage our patients very differently. If it's a chronic condition, it's going to get very complicated. And if it's acutely acquired, this is the kind of heart that may need urgent mechanical support, for one example. So if you're new to the eyeball method, I hope you can be reassured by this side-by-side comparison of these 4 categories, that when comparing hyperdynamic to normal to the mild, moderate, and severe spectrum, that with suitable practice and training in looking at a number of these, it becomes relatively straightforward to categorize these and to make clinical decisions around these types of hearts. Of course, we look at other views than just the parasternal long axis when it comes to goal-directed echo, and the short axis is one of the best views for gross left ventricular function eyeball assessment, and that is shown here. You can appreciate at the papillary muscle view, which is our preferred cut in the short axis for a gross approximation of LV function, that the differences between these 4, I think, are fairly straightforward when shown side by side. With some additional practice, you can nail them without the need for the comparison views. Of course, we can assess the left ventricle in the apical projection as well as subcostal views, and we do so routinely. However, the parasternals are perhaps the easiest for us to interpret when first starting out. And assessing the LV with the eyeball approach has tremendous implications, as I've mentioned already, for our patients, and the choice of vasoactive medications, volume administration, mechanical support, and prognostic information as well. So the eyeball method for LV function, it works for me 9.5 times out of 10. And it drastically influences patient care on a regular basis for me, including just taking LV considerations off the table, which is as important sometimes as finding a smoking gun in that left ventricle, as many of you have heard from me in the past. Sometimes the ability to go a little bit deeper and get a little bit more slick and quantitative with the left ventricle in particular can provide more insight. And I'd like to discuss that with particular view, not of doing ejection fractions, because ejection fractions are kind of a made-up construct. It's not physiologically relevant. What is physiologically relevant is stroke volume. And stroke volume determination can be done relatively easily at the bedside. So we need to review how you do this briefly. Now, this webinar cannot cover this in full detail. That's a tutorial in its own right. But just to remind you or prep you for the learning you may yet do, you need the LVOT diameter, which is captured in the parasternal long axis. Most people is 2 centimeters plus or minus 0.2 centimeters. And then once we have that, we need to get what's called the VTI, which is a velocity time integral from the left ventricular outflow tract, captured here. And you can see it's obtained typically from an apical 5-chamber, or you can do an apical 3-chamber view, and putting a pulse wave Doppler gate in the LVOT, generating peak triangles that are the sum velocity of all the red cells leaving the left ventricle. And through a caliper-based approach, you can measure the area under the curve for this systolic event. And as you can see here, painstakingly tracing with calipers. This eventually gives us a number that we can then plug into a mathematical formula. Thankfully, the machine will do it for us, and it becomes relatively straightforward on most point-of-care machines. So we've measured the LVT diameter. Well, we need to now punch this into an equation because we're ultimately going to be solving for a volume. So this forms the base of a cylinder that's leaving the left ventricle, and the math is therefore the area of the base of a cylinder, which is a circle. And so we come up with 3.46 centimeters squared. We take the VTI, which is 14.2 centimeters, and we multiply it by our above number to give us a volume. So in this particular example, this patient's stroke volume is around 50 cc's, which is in the low normal range. And now, many of you perhaps have done that technique, and it becomes relatively straightforward after, a few dozen executions. However, many of us look at that and say, geez, for the few times, that you're going to tell me that might be helpful, I don't know if it's just worth understanding Doppler physics and getting into this level of detail. And so the question, of course, is the juice worth the squeeze? Because after all, we can see in these two cases here, we have the top case we can see has what appears to be a significantly or appreciably depressed left ventricle with some regional wall motion abnormalities and pretty non-reassuring systolic function. And look what you get. You get a VTI, which is 14.4. And without knowing the diameter of the LVOT, I can tell you that that's low, with normal VTI being about 18 to 20. So right away, you know that this guy, both from 2D and from Doppler, has poor output. I'm not sure you needed to go to the extra trouble to get the VTI to tell you that this heart is less strong than this heart, which looks normal on 2D, and the VTI is in the normal range, 18 to 20, it's 20.2. So these examples where there's concordance, and that's the key theme, I think, for what we're about to talk about, concordance between the Doppler data and what you assess with your eyeballs, there's no value added. So that's the way to think about it. If there's concordance, there's no real value between all that extra work has told you what you already knew. The patient does, in the bottom case, have preserved systolic function, and at the top of the screen, systolic function is depressed, and lo and behold, stroke volume is also depressed. So concordance is of little excitement to us. We get excited when things aren't quite what meets the eye. And so that will be the focus of the next few slides, where we'll review 3 cases where discordance or additional information can sometimes, I think, be worth the effort. So our first case is a 35-year-old male who presents with an ST elevation MI and shock with respiratory failure after having his artery managed with a stent to his LAD. He's recovering in the ICU. A effort to get a parasternal long axis, though complicated intermittently by ventilation. I think you'll be able to see here through a few views that the ventricle, by eyeball method, the short axis perhaps being very telling here, is depressed. You've got regional wall motion in the anterior septum, which is down significantly, and even the lateral inferior walls aren't really picking up their slack. So you've got normal right ventricle, no pericardial effusion. The IVC looks within normal range with no major changes. So we've got a depressed ventricle post-STEMI. We decide to go a bit deeper. We measured the LVOT diameter at mid-systole, and we measure the VTI from the apical 5 chamber, which at outset looks low, 13.5 centimeters. Remember, I told you 18 to 20 is normal. Remember those numbers. So with that information, we do what maybe we might have done anyway without this information. We started some inotropy, saying we've got a stroke volume issue. The stroke volume issue is related to a contractility problem, recalling, of course, that stroke volume is a summation of preload, contractility, and afterload. And really, this boils down to, at the minimum, a contractility problem. We have drugs that can help this. So dobutamine was started at a generous dose. And there's many ways to follow the success or efficacy of an intervention. But when it comes to numbers and the repeatability and non-invasive and low cost, really, this is going to be maybe the best bang for your buck. Go back to the bedside, rattle off that same apical 5 chamber view, and have a look at this VTI. So we went up to 19.8 from 13.5 with the initiation of some meds. So we know now we've fixed and recruited some of the contractility for this patient in shock. We know that we can likely reach resuscitative targets. We can call off the balloon pump. We can concentrate then on the ventilation side of things. We can consider diuresis because we've now achieved renal perfusion, presumably with regained stroke volume. So everything looks a bit different. And this was only obtained about 35 minutes after the initiation of the dobutamine. So we immediately have this gratification. And so it's a really rewarding case to follow up that dobutamine initiation. So this case really highlights that, we have confirmed depressed stroke volume on 2D standard, and by 2D standards, as well as using the Doppler approach. The appropriate intervention of inotrope initiation was probably called for by either approach, eyeball or Doppler. And the real value, though, we saw was achieving that baseline Doppler so we could follow our intervention. And so the Doppler data is easily repeatable and gives you that quantitative, really rewarding physiologic feedback for these complex high mortality cases. So that's what I would try to ram home from this case. Nothing too fancy here. We have a depressed ventricle, we start some inotropes, but we see right away it's working, and we can move on to other aspects of the patient's multi-organ failure. Case 2, a 51-year-old male with alcohol withdrawal who's ventilated and is hypotensive in your ICU, or perhaps in your emergency room, or wherever you want to imagine yourself caring for this sick patient. So we carry out a goal-directed echo, of course, starting in the parasternal long axis. And, at first glance, I think you guys are looking at the eyeball approach. I hope so. The mitral valve looks pretty good. The thickening and excursion of the 2 walls that are seen on this view of the LV look pretty good. No catastrophic effusion. We look to be shaping up okay. So not obviously either right or left ventricular failure from what we can see from either of these views. Now looking at the short axis, things look pretty good. Maybe a little bit hyperdynamic, but normal, not really a problem. But, we go a bit deeper. We get an apical 5 chamber view, we put the pulse wave Doppler in the LVOT, and we generate a VTI. And whoa, look at this, where we might expect a VTI of between 18 and 20, as I've talked about a number of times now. We're getting a VTI of 13.8. And this is the largest VTI of the group on the screen. And by the way, if you are uncertain or the patient's in AFib, you can take a number of measurements and average them out would be the traditional recommendation to get a great sense of the patient's cardiac output. But this tells us, that we got a problem. And remembering, stroke volume is contractility, preload, and afterload. Well, the patient's hypotensive and has good contractility on the 2D assessment. So now we have an interesting case of discordance rather than concordance, which we've seen quite a bit. So we have a reassuring EF, so to speak, or systolic function by our 2D assessment, but the VTI tells us a different story. So stroke volume's down, and we can actually say that despite a reassuring echo by 2D standards, we've actually unmasked there's a cardiac portion to this, or unmasked the underlying physiology. And really, this is a preload problem until proven otherwise in this kind of patient. There could be other causes, of course, but really, this is a preload problem until proven otherwise. So, easy thing to do here is administer volume for this patient and repeat the study. And the key thing here is that by doing Doppler, we gave ourselves information that wouldn't have otherwise been available. Because rest assured, this patient had an IVC ultrasound, and it was indeterminate, of course, because he's spontaneously breathing on a ventilator, and most IVCs in those patients don't give us the signal we need to identify hypovolemia. So this patient benefited from volume, and VTI, of course, went up. And if VTI goes up, you plug it into the equation. That means your stroke volume goes up, which means your cardiac output goes up, which means your hypotension becomes resolved. And my question to you is, if you're just using 2D, and granted, if you're using 2D echo, you're probably doing better than a lot of the folks in your practice, but take maybe a step further. And if you aren't using quantitative approaches, maybe you're missing some of these interesting discordant cases. Now, this is a case of volume administration. This isn't apt to have led to death if it went unrecognized, but there is a tremendous pleasure, as we all know, in identifying the actual cause of the patient's problems and identifying the root physiology at the bedside, especially now that we've abandoned invasive monitoring largely in critical care areas. This restores that quantitative and precision instrumentation that I think many of us have been missing. Case 3 is a little more complicated. 49-year-old female, known pulmonary hypertension, is admitted to your ICU with respiratory failure of hypoxemic origin, and has some ARDS felt to be due to some pneumonia. Complicated. On day 2, the patient starts to crump. And the subacute deteriorations are always very concerning in my experience in these types of patients. And you need good data to manage them because it's typically not your average problems such as volume administration or source control that tips these people over. It's often a very complex interplay, especially in these people with right heart failure of their multiple organs that are in some delicate balance. So you really need good data. So let's have a look under the hood here and see what the parasternal long axis shows, which looks like the RVOT looks generous and the LV is empty, consistent with obstructive physiology and a small pericardial effusion. This is really highlighted here on the short axis where you've got a D-shaped left ventricle, and the RV is large with that pericardial effusion again. Subcostal view, again, highlights now the first side-by-side chamber comparison. The RV is much larger than the LV. No big surprise there. You've got right atrial enlargement, which is massive, and the effusion is, again, well seen. So, does this tell us how to manage this complex patient? Well, not overly well. And really the concern here now is you've got previous pulmonary hypertension. You've got now somebody on a ventilator with hypoxemic vasoconstriction, ARDS, pneumonia causing a cor pulmonale state that's an acute on chronic picture. And these cases are very difficult to manage, partly because there's no single right answer and there's many possible approaches depending on the patient age and illness trajectory and cause of their pulmonary hypertension. It's a complex case. All that being said, there is a lot of increasing interest and great review article here by Greg Schmidt that discusses the echo-guided approach to managing these kind of complex patients with right heart failure. The other big heavyweight in this area is the Frenchman Antoine Vieillard-Baron, whose papers I would strongly suggest any of you read. But before we talk about exactly what to do in this past case, I want to talk about RV function for a second. And I want to talk about something called TAPSE, which I expect many of you have heard of and some of you may employ on a regular basis. And really the TAPSE is the right-sided quantitative approach to how well the right ventricular systolic function is working. And we kind of like this, and we don't mind it as much as ejection fraction on the left side because it's really easy to do. And everyone gets kind of excited about doing TAPSEs because it sort of feels advanced. And the truth is it's easy, and I've never really seen it influence outcomes more than an eyeball assessment. But I thought I'd briefly at least describe the technique. Here you have a different patient with where the LV isn't totally super well seen, but we can appreciate that the RV is dysfunctional. It looks quite large. It looks like there's apical sharing between the RV and LV. And, we can see that the tricuspid annulus, which is how you just visually would assess for RV function, doesn't seem to slide all that vertically towards its own apex. Subjectively, you could just say the RV function is systolically depressed, and it also shows features of septal encroachment in the LV and RV enlargement. This is all consistent with cor pulmonale with decreased systolic function. I don't think there's a need to go deeper than this. However, if you wish to, it's done with an M mode. So you're going to watch an M mode line go through that tricuspid annulus. And when you feel you've kind of got a good hunk of tissue there to go through, you just enable the M mode. And it's going to give you the farthest point down here where you can see the vertical slide of the tricuspid valve annulus. Now, this is important to note that because time is the x-axis, the absolute vertical distance that the tricuspid annulus travels can be measured either in a straight up or down approach or a diagonal approach. The machine discounts any vertical or any horizontal contribution and just does the absolute vertical distance between any 2 points. So all that being said, we here have a TAPSE of nearly 11 millimeters, which is highly abnormal. A normal TAPSE, or basically the cut line for the normal abnormal, I use a cutoff of 16 or below, is abnormal, as do most I work with. And so if your TAPSE is below 16 millimeters or 16 millimeters or below, then you're dealing with objectively measured dysfunctional RV systolic function. So does that add anything to the situation? I'm not entirely sure. Is it easy to do and takes about 5 seconds? Absolutely. So it's kind of an easy quantitative approach, which is obviously part of the theme of this discussion and discussing whether or not Doppler or quantitative measures are worth it. I think this one, I can take it or leave it. It's so easy to do that I don't mind doing it, but it'll depend a little bit on your practice and on the culture at your center. But there you go, TAPSE in about 2.5 minutes. Back to our case, though, very exciting. So this 49-year-old female with awful right heart failure. We're going to go under the hood and look a bit deeper because this case is complicated. We need good data. So we're going to take the LVOT diameter, and we measure that to be 1.92. Remember, I told you most people are almost right around 2 centimeters. And we're going to measure the VTI. And the VTI is measured at a whopping 11 centimeters. Not very significant. Again, we saw the LV contracted well, and we see it in the upper left here. Great LV systolic function, but lousy output. Why? Well, of course, that's consistent with right-sided obstructive physiology. No blood is getting to the LV, so even though it might meet hyperdynamic criteria, or at least normal criteria, it has a lousy stroke volume because it has a relative preload problem. However, this isn't a total body preload problem, it's just an LV preload problem. We need to find a way to get blood across to the left side to be able to bump up this VTI, because when you punch in the numbers and you do the math, your stroke volume is just above 30 cc's, with normal stroke volume based on average sizes being around 60 cc's or more. So we've got some serious work to do in this patient who has increasing markers of shock, including a rising lactate. Now, which approach do we take to managing this right ventricle? Do we take inotropes? Do we take RV afterload reduction? What do we do? Well, in this case, we took a slightly more interesting approach. We acknowledge that the right ventricle encroaching on the left ventricle is partly because it's acting as a capacitance chamber, holding a lot of volume that it doesn't need and it's not being effective with. So we put it on a weight loss strategy. We gave this patient 80 milligrams of furosemide based around some encouragement from that review article I showed you from Greg Schmidt, as well as this article below, which discusses this strategy and has some early promising results. So we weren't sure this was going to work, and we weren't putting all our eggs in this basket, but we did try this approach. And sure enough, the patient started putting out urine, which doesn't necessarily mean the patient's quite getting any better. That's a natural response to a hefty dose of furosemide. So we needed to check on the success of this intervention, which we were going to measure in how well the left-sided output improved, of course. And, we can do this subjectively. And one of the interesting things here is that this is the before and after images. We can see that the septum, while it still has its paradox, it is no longer completely flattened. We can see that the LV is now much more full, and we can see that because it's much more full, the relative appearance of that pericardial effusion is significantly diminished, which is an interesting finding in its own right, sort of the optical illusion of a small pericardial effusion when you've got an underfilled ventricle. But the big thing is that we see that the LV looks altogether healthier after the RV was put on this weight loss strategy mediated by a very simple intervention, nothing overly complicated. And so from a visual point of view, we were satisfied, but what about the Doppler data? And so we went back to the apical 5 chamber view, we put down our pulse wave Doppler in the LVOT, and sure enough, we're extremely satisfied with our results. So we now note that the patient is a little bit more tachycardic, each stroke volume occurring a little more frequently than in our original information, but we see here that the VTI has improved to 20 centimeters, which, knowing that the radius of the LVOT will have remained the same, we can take this as a obvious improvement in the stroke volume, a nearly doubling because of offloading the right ventricle of that excess volume and changing the geometry of the entire heart effectively with aggressive diuresis, which is not an experimental strategy, but is a strategy that many find counterintuitive for a shocked patient to remove volume. And so it's so gratifying to be able to have an objective case scenario that highlights this. And I must give an acknowledgement to one of the trainees at my center, Dr. Vincent Lau, who obtained these cases, and he's an outstanding echocardiographer. And so he's captured this, the result of this intervention beautifully in this case series. So thank you, Dr. Lau. So lesson 3 for this more complicated case is that when you're doing multiple interventions, so maybe we adjusted the PEEP and maybe we added some milrinone, but we would do all of those things one at a time when we have a bit of time and repeat our hemodynamic assessment to be able to determine what worked best for these patients. Enough of protocolized medicine. You're an expert resuscitative doctor. You're at the bedside. You have this quantitative approach. Use it to be able to identify what worked. Kitchen sink therapy is useful for patients who are dying rapidly, but when you have a bit of time, repeat the study, determine what works, determine what doesn't, and then, use that feedback accordingly. We found tremendous benefit with diuresis. We continued that approach to the patient's betterment, in this case with the shock resolving in light of the fact that they had actually just received too much volume and the RV failed as a result of volume overload. So it's been a bit of a wandering whirlwind tour, but I'd like to conclude with a few comments. And one of the key themes, as you'll recall, is that discordance between Doppler and 2D analysis is where we can get very excited about Doppler, and where we can say, you'd need probably only 1 or 2 cases where you learn something different about the patient's physiology, as I've shown you in a couple of these cases, than what you might have expected based on your 2D information to convince you that this may be worth it. The juice may be worth the squeeze, to put it another way. And this is a point of evolution for us at the bedside. There's not a ton of practitioners using detailed stroke volume assessments, so I'm so interested in your own experiences with this, and we can open that up for questions very shortly, and I'd love to hear some of your experiences or questions about putting that into practice. Now, I must also emphasize, however, that the approach to Doppler is one based in quantitative methods as well. It's sensitive to some technical methods as well, which could really magnify your errors if you're not well trained. So the training is important here, just as it is for 2D. And when you do find those discordant results, it can really influence your management decisions. Now, I must conclude, however, with my overarching conclusion, which is that 2D methods still 95% of the time are all you need. And you can watch this webinar and be satisfied that that's cool. Some guys who are really passionate about it do this technique, but majority of the time you're doing a superb job. If you're a well-trained 2D point of care echo person, then you are doing superb work, and you needn't reconsider that based on this webinar. However, if you're itching to get in on these techniques, then perhaps I've given you a bit of an idea about how you may use this stuff. So with that, I will finish my presentation, and we will open the floor to questions or comments. And I want to thank you so much for listening, and thank you to Sonosite for allowing me to speak to you about this emerging and interesting topic.